your PowerPoint, guys. And as you would like me to transition, just let me know to go to the next screen. Thank you so much for joining us.
Thank you very much for inviting us. We're going to tag team today. So Dr. Reynoso is going to talk a little bit about more about food, and I'm going to talk a bit more about the program in general. Some of you may not know, but Eskenazi Health is part of Health and Hospital Corporation of Marion County. Marion County's Indianapolis, more or less. And within Health and Hospital Corporation, we also have the Marion County Public Health Department. And over the many years, we've collaborated on some projects as food is medicine. So some of the initiatives here represent Eskenazi and Marion County Public Health Department, but also they represent a lot of work by partners in the community. So this is going to be a whirlwind tour of the last 30 years, and then we'll hand it over to Dr. Reynoso. So next slide. I have left out every slide that talks about the importance of social determinants of health. So we're starting off with the notion that this group is aware of social determinants and the importance of food and nutrition in particular. But our goals here were to integrate social care into our medical care practices, to engage our network of community partners. And a longer term goal is to reduce disparities in healthcare outcomes and to improve longevity. Many of you are probably familiar with this report from the Polis Center and the Richard M. Fairbanks Foundation, but it demonstrates that we have about a 17-year longevity gap between our outlying counties and the urban core in Indianapolis. And you can find these for just about any large city, Boston or LA or New York City, where you show that more affluent areas are living 10 and 20 years longer than some of our more challenged neighborhoods. Next slide. So chapter one, I'm going to go through 6 chapters fairly quickly here, and here we're covering about 30 years all at once. But what you had at Eskenazi over the years was a number of small centers of excellence. You know, somebody that was doing really cool work, maybe a diabetes prevention program or produce prescription, or someone had done a randomized clinical trial, say, of medically tailored meals. Lots of small programs, but what our leadership asked was, what does it take to make these strategies system wide, to make them really part of the culture and the fabric of care at Eskenazi? Next. So now we're up to 2019, and this is really where Dr. Reynoso and I started working together on social determinants. And we were starting out trying to conceptualize what a system wide infrastructure might even look like. What did that mean? And then cataloging the assets at Eskenazi Health. What were we doing already, and what were these programs that had been around for a while and really had been quite innovative for decades. Then in 2020, we received about $500,000 in funding from the Eskenazi Health Foundation.
Yeah, so actually
And
one interesting thing that I will even put as a ploy to those
and
famous fellows here when I
I'll
when I
announce that someone needs
data
to
is that
mute.
we did collect data on what primary
I'm going to keep going, Julie, because maybe you'll be able to follow. The 500,000 was to help us recruit new leadership, and we recognized that Dr. Reynoso and I were not the experts in neighborhood redevelopment and not necessarily the experts in community partnerships. And this allowed us to recruit two very talented folks to our team. And I'm going to show you some pictures of them a little bit later. That took us to 2021. And with this new team of people with community expertise and expertise inside the health system, we started working on what it might look like in our electronic health system to integrate the social care into the medical care workflows. So imagine that you were making screening for food insecurity and referral the same way that you might refer somebody for an x-ray, or the same way that you might consider the workflows for management of diabetes. And then we now had the capacity to greatly expand our community and referral workflows and begin to develop partners who would be expecting referrals from our screening program. Next. So now we're up to 2022, and largely through work that Dr. Reynoso accomplished, we had some fairly significant changes in the workflow, but we also engaged a whole new workforce. These are names that you would be familiar with, like community health workers, but we also started a new group called Community Health Weavers. You can kind of think of the workers as being navigators within the health system, and the weavers were the navigators within the community, but both with expertise on one side of that continuum. And then we also employ 4 SNAP counselors that are helping folks who are food insecure get hooked up to the supplemental nutrition and assistance program, and they have been quite busy. And then other groups like peer recovery coaches and doulas, and this is a workforce that's about 200 people strong now at Eskenazi Health, and that does not count the similar workers and other names I haven't said who are in the Marion County Public Health Department. So then we applied for another round of funding from the Eskenazi Health Foundation to build out a strategic plan for health equity zones, and then to expand some of our own services where we could provide vouchers for patients in clinic, and they could redeem those vouchers at a Fresh for You market concept that our team developed. Next slide. That brings us up to 2023, and what we found is that we needed a lot more help with project management. I have greatly oversimplified all the programs that got launched in this period of time, and the number of places that those projects intersect with the healthcare system or the health department or Health and Hospital Corporation or one of our partners. And it is truly a great deal of effort, and it requires a special expertise to integrate all of this within the structure of the what amounts to a very complicated healthcare system. I haven't mentioned it as much, but we have a network of federally qualified health centers. They are based in neighborhoods of high need. And we also have a network of community mental health centers under the umbrella of Eskenazi Health. And that has been the main site of this work. But imagine, of course, that they're very busy with their medical and mental health care as well. So that effort to continue to integrate our work within the existing infrastructure has become a effort on its own. And then just a few months ago, we launched 3 of our health equity zones, and that'll take us to the next slide. These, if you think about, especially from an analysis standpoint, and my background is in research, we have tended to think of people or patients who were nested within providers who were nested within health centers. But with the help of our colleagues, we've expanded that notion that these health centers are embedded within health equity zones. And so if you click one more, Julia, you kind of see to move into this true integration with our community partners, we have to think about that patient that, yes, they're embedded within the health center and within a health equity zone, but the health equity zone itself is embedded within a neighborhood, and that neighborhood has its own assets and its own opportunities to serve patients that come through our health centers, but we've begun to think of ourselves more of a grand central station in terms of moving patients to assets in their neighborhood. Next slide. So to bring some structure to what is a very complex environment within these neighborhoods, we defined health equity zones, which are geographic areas where we have a neighborhood-based health clinic, and we have formal partnerships with community-based organizations. Those partnerships allow us to create a shared vision and then joint implementation. And the goal then is to address social determinants of health, but also to be more vocal as a health center about issues such as racism and racial equity and health disparities and limited economic mobility. The graphics there are three of our current partners that represent each of our three first health equity zones. That's the International Marketplace Coalition, the United Northeast Corporation, and then Cafe on the Far East side. So if you want to know, like, where are these three equity zones? On the far west side of Indianapolis, it's that dark green colored area. In the middle, you see Near East Side, which is kind of a pinkish purple. And then the Far East Side is Cafe. For those of you familiar with Indianapolis, those three health centers of Eskenazi run along the 38th Street corridor. And they also provide services from Marion County Public Health Department, which also has services in those neighborhoods. Next slide. So this is our team. It's been growing from 2020 to 2022. Dr. Reynoso, you're going to hear from next, but I just want to say that even though this is a team of 6 or 8 or 10 people on most days, it's actually hundreds of people within Health and Hospital Corporation and in these partnerships that have taken part. So I'm going to hand the virtual baton over to Dr. Reynoso, who's going to talk about our Food is Medicine program.
Thank you, Dr. Callahan, and thank you everyone for inviting us here today. We can go to the next slide. I'm going to more specifically look at Eskenazi Health and Food as Medicine, nutrition related efforts with social determinants of health. I'm starting at 2019, but there were many, many years, probably even before I was born, well, actually for sure before I was born, where the health system was engaged in food as medicine. And things like Meals on Wheels and medically tailored meals, a lot of the nutrition programming really pre-exists the start of this slide. So I don't, but we had to start somewhere. Otherwise, we would never finish up to let Parkview present to us their work as well. So in 2019, it wasn't that food insecurity screening wasn't happening prior to that, but that really marks where we integrated it into the electronic medical record system so that it could be done systematically across the health system. And really that is a first pivotal step. If we can't do health related social needs screening, then we aren't able to best connect people to the resources in the community. But the goal of just screening in order to screen and get data and know who's food insecure has never been a goal of ours. To us, it's not respectful to ask people questions about their needs without the intention of really building upon the infrastructure, both internally and then those connections in the community that can meet those needs when they're identified. In 2022, we added to that screening process by adding the SNAP question to our hunger vital signs questions, which was important additionally as we were looking to how we can connect people to a resource that is meaningful to them as they're working to give proper nutrition to themselves and their families. Running through the next part, which is more on the infrastructure of the resources and connecting patients and families to what they need. In 2015, we opened Crooked Creek Food Pantry, co-located in one of our 14 federally qualified health centers. And from that, our original intent was that might be something we could systematize at all of our health centers. And as we move forward, you'll see a shift in our approach. We continue to have Crooked Creek serving a large portion of our patients in the community, but moving forward and looking at what we could do as a health system, we started with a lot more of the food as medicine programming with our dietitian and healthy me teams, and specifically group visits around food as medicine starting in 2019 in partnership with Crooked Creek Food Pantry. Moving to 2020 during the pandemic, really shifted to emergency food distribution with the CPAP food and partnership with Gleaners, and had mobile food distributions in the county. During that time is also when we integrated Aunt Bertha, which is now Find Help, into our EMR so that it's able to best pull up resources based on the patient's zip code and address for fine-tuning how we can connect patients. In 2021, we opened our Fresh For You Market Pantry Hybrid, which is something we'll talk about on subsequent slides, but is a hybrid version of what it means to provide a market for a neighborhood that doesn't have access to reasonably priced healthy food options, and also the pantry portion of the need for those who are having difficulty with putting food on the table for their families. In 2022, as Dr. Callahan said, we're really excited for the SNAP outreach coordinators internally. We saw that as a big need of being able to connect our patients to that resource who qualify. And then now this year, rolling out an expanded version of the Fresh For You Market and auto print of resources. Next slide. I'm going to go back to really look at some of these. This is a lot messier or less messy drawing of trying to put on paper some of what we are doing both within Eskenazi and the our partners with the Marion County Health Department. But essentially, when we're looking at food as medicine, we know there's three main categories of barriers that keep people from having nutrition that not only prevents but helps treat a lot of the chronic diseases that we see. So for on the far left of the picture, we have individuals who live in neighborhoods that really have no access to fresh produce or groceries, often being dependent on convenience stores. So if there's lack of transportation. So in that area, we have a lot of partnerships looking how we can support local markets, other resources, retail, community-based organizations, and then that goes into our health equity zones of looking what does the neighborhood have for food. And all of those sort of leading to in the middle our Fresh For You Market Pantry Hybrid model that hopefully to ultimately have the neighborhood nutrition access and food sovereignty for each of the neighborhoods surrounding our community health centers. On the left, we have what people traditionally think of food insecurity or nutrition insecurity, where really it's a problem of being able to afford buying the foods that you need to live a healthy life. And so in this, it starts early on with the health centers doing screening and documenting that in a way that we can in real time connect patients to resources. And then the food network across the city and the county of multiple different organizations and pantries that are involved in helping individuals that are having difficulty affording food. Programs like SNAP and WIC, multiple Community Compass, which is a platform to help connect individuals to food. And what we hope that ultimately leads to is food security and nutrition independence for our families. And then on the top, the third area is really having the nutrition education. This is really key for us as a health system. You know, once you have access to the food, you really understand the food options that are best for you and your family based on your medical diagnoses to not only treat and prevent illness. So up here, a lot of the nutrition programming, medically tailored meals, Produce RX, our partnership with the Marion County Health Department and the state for a lot of these program incentives. Next slide. I put in a screenshot. We use Epic as our EMR, but this is what the questions look like for food. We have right now 3 questions under our food domain, the 2 hunger vital sign questions, and then the additional SNAP question that we added. This question we added, no, I'd like additional information or assistance, because that allows us to have a work queue that our SNAP outreach coordinators can then also, it's a referral process where I can refer a patient, but they can also go back and work the work queue, which come to find out we'll need quite a large workforce for the number of people who would really need it or food insecure and would like to connect to SNAP outreach. Next slide. Really, you know, we have the asking, which is the screening, we have the listening, and that when you screen someone, really what are the needs? And we started in 2019 where we had over 10,000 visits that had food insecurity screening documented within a 12-month rolling period. And there's been significant work going into this. I was really proud of ending the year with over 50,000 visits, having a documented hunger vitals screening in the year. This last 2 months, we're just blowing it out of the park. In April, we screened more individual visits than we did the entire year of 2019. And part of that is the culture of the health system of recognizing that hunger vital signs may be as important as checking their blood pressure. You know, it is so impactful to people's health when they have unmet social need that having a shift in value. So this was made as one of the quality metrics that is a provider incentive for primary care, as well as a staff incentive to screen for food insecurity. And with that, you can see really just the first part of April already having done more than the entire year of 2019. As far as the numbers of food insecure individuals, you can see on the other graph, we run around really in the 30% range of all of our patients are identified as food insecure when they're screened. So we're starting to get very large numbers as our screening rates are going up of individuals that we then have the opportunity to connect them to resources and really start seeing how we can best address those needs. Next slide. With responding, as we are identifying more individuals who are food insecure, and I'm just focusing on one domain, even though our social determinants of health is really looking at multiple domains, we recognize that not only are we going to need to work internally for our infrastructure, for resources, but also be cognizant that we could very well overrun many of our community partners who are doing this work. Because as we're identifying and referring, even for you know, a very close partner of Crooked Creek Food Pantry that's co-located, the numbers that are now being seen and run through with our increased screening is bringing them really beyond space capacity. And so trying to make sure that we're keeping up on both of those areas. Next slide. For also as a response, you know, we learned when we talked to FSSA that very large numbers do not get SNAP even when they start the process, even though they do qualify, because it's complicated, and you know, even getting everything back in that's needed is a struggle. If you add on other language barriers and other electronic internet access, it was causing a barrier for a lot of our patients to not get SNAP. So looking here, just in April, we had 9,500 unique patients that were screened during April, and over 1,250 just in the month of April indicated that they wanted more information about SNAP. So with a small workforce of working to assist people with SNAP applications, we know this is an area that's growing very quickly, and we're looking to see how we can continue to sustain that real-time access for patients to get assistance with the application process. Next slide. The last two slides, really, I'm going to talk about what I get overexcited, so someone's probably going to have to cut me off here, but the Fresh for You market model is really, there's health systems that have food pantries or food pharmacies. And then, for example, ProMedica, who opened a grocery in one of the neighborhoods in Toledo, who have the market. And this model for us is really bringing everything together, where we can have a market where individuals can purchase at fair prices, wonderful fresh produce, things that all of us would want to be purchasing, and have access to that in the neighborhood, as well as being able in our within our health system. So patients that are food insecure can get a voucher, and really no one knows if they're shopping with a credit card, cash, or a voucher. So it gives real dignity to the process. And then the third part is it really opportunity to do nutrition programming and cooking education along with the market. So this is a picture of the market on our main campus. And next slide. This year we are
Did she freeze, Julia, or is it me? She did. Well, I'll finish. Are you back, Dr. Reynoso? We
Am
we
I
can hear
back?
we can hear the birds, so we think you might be back.
All right. Well, maybe I got overly excited. Can you still hear me now?
Yes.
So this is our mobile version of the Fresh for You market. So really all the proceeds of food that's sold, which is at, regular retail pricing, grocery, goes back into our voucher system. And we're working to later this summer auto print vouchers for $30 for all of our patients who are food insecure that can be utilized at the market. And then additionally, making sure that we are able to accept SNAP, so that individuals who live in communities that don't have access to the market portion of it can also utilize their SNAP. So there's a lot more to come, but it's at very exciting times at Eskenazi, both in our progress in the infrastructure of screening to identify health-related social needs, but in our progress of both our external partnerships and our internal infrastructure to be able to better connect individuals to the services that they need. And with that, I will, I don't know if we're taking time for questions or if maybe at the end.
Yeah, we can take some time for a few questions here. Maybe if I, okay, there we go. We can take some time for a few questions. Does anyone have any questions right away for Eskenazi's team before we move over to our Parkview Health presentation?
Hi, my name is Olivia Taylor. I had a quick question. I work with a nonprofit organization called Black Women in Charge. And I was just wondering, for people who may show signs of hunger via your questionnaire, how do you monitor that they're succeeding? And how do you also monitor, like, if they can't get to grocery stores, like what programs help them with that?
Yeah. So
Did she freeze for you all as well?
Yeah, I think
Yeah.
she froze again. There's one of the things that I'll say about social determinants in general is that it's sort of the holy grail to be able to find when we refer someone for community resources if it's actually helped. For some of these, we're able to tell because the person reports back to us that it worked. But one of our goals and one of the things that Dr. Reynoso mentioned with the vouchers, we're hoping to be able to track those vouchers through our system so we know that the patient was able to get them. But Dr. Reynoso sort of limited her comments for this audience around food, but one of our other high priority areas is transportation. One of the reasons for the mobile Fresh for You market, the bus that she had on her last slide, is because people don't have access to transportation. So it's going to be parked at some community sites as well as some clinical sites.
and then
Sorry,
I'm
Deanna, you
sorry,
went away again.
I'm having a bad internet day, but additionally, we do have the entire workforce that Dr. Callahan mentioned. So we have community health workers. We have individuals that might not even be able to make it to the bus, even if it's very close. So the ability to have community health workers that can take food out to the home is an ongoing effort as well. So making sure that we do understand that many of the health related social factors go together and stack up, and sort of one barrier makes the other barrier even more difficult to overcome. So I thank you for that question, and I think it's going to have to be multifaceted. The way that we approach everyone's needs are different and can be very complex, and being aware of that and looking to see how we can make sure that we're not leaving individuals out of being able to connect to resources because of other barriers.
Thank you. Thank you for answering my question.
Wonderful. Thank you so much. And we've got some excitement in the chat about the launch and just your amazing program. So thank you so much, Eskenazi team. And we'll move on to Parkview Health. If Dr. Giaquinta and Lisa, if you want to get started.
Great. Thank you so much, Julia. I'm Sarah Giaquinta. It's really nice to be here with you today, and I'm here with my colleague Lisa, and it's an honor to get to present alongside Eskenazi Health. Obviously, they're doing a lot of incredible work in the community, and so just excited to be here today to share what we are doing up in Northeast Indiana as well. So go ahead and go to the next slide, Lisa. So great minds think alike, and it looks like we are starting with a very similar slide. What we know about social determinants of health is that where you live matters. And it's been said that your zip code can influence your health outcomes more so than your genetic code. And I have seen the Indianapolis study that they referenced many times. And I think we often think about these inequities and these differences in life expectancies really being associated with big cities, right? That's a big city problem. Fort Wayne is a much smaller area, but we see the exact same issues, the exact same inequities, even in a smaller city as Indianapolis. And so if you look at this, it kind of looks a little bit messy, but just to orient you, This is our downtown area. And you can see here, these are kind of more of the suburban areas, southwest and northwest. Life expectancy is 86, 82 in those areas. And when you get to the southeast area of Fort Wayne, which we know has the highest rates of poverty and a lot of other barriers to accessing the things that you need to have a healthy life, we see that there is a really dramatic change in life expectancy. So in this census tract, 66, 74, 72. So in some areas we have a nearly 20-year gap in Fort Wayne around life expectancy. So we do have the same issues here in Northeast Indiana that you see in other big cities. If you go to the next slide. And we know that social determinants of health really impact, again, our ability to be healthy. So what we see here is in that southeast side of Fort Wayne that I drew attention to, what we know is this area, it's a food desert, it has our highest rates of poverty, it has our highest rates of poor living conditions, and it's a medically underserved area. And so when you have all of those risk factors layering like that, these are the kind of health outcomes that you see. So high blood pressure among adults age 18 and older. In this neighborhood, nearly 50%. Oh, I guess they're not seeing my cursor, but in this dark orange area, nearly 50% of the neighborhood in that area has been diagnosed with high blood pressure. If you jump over to the diabetes, again, that dark area, nearly 20% of adults in that area have diabetes. So again, we know there's a huge impact of these social drivers on the health of our communities. Go ahead and go to the next slide. So just to orient us all, I did throw in a slide on social determinants of health, but these are the conditions in which people are born, grow, live, work, worship, age, and play. And what we know is that those social determinants and health behaviors together contribute to 80% of modifiable factors that influence health. And that's obviously why we're all here today. So next slide. And traditionally in healthcare, we have really approached care of our patient population in this sense of equality, right? So if this top right one, what we have wanted to do is treat everyone the same. We want to do the same thing for the same people because we feel like that's equal and fair. But what we really need to do in healthcare is shift it to a narrative of equity. And so you can see on this bottom left hand, we are looking at how do I understand the individual barriers, the individual risk factors, how do we identify those needs of our patient population so that we can provide the same opportunity for them to be healthy as the other people that we see in our clinic. And so foundational to this, to approaching from this equity lens, is having tools that identify and address these inequities. And that's how we get to screening for social determinants of health. So next slide. So I'm going to turn it over to Lisa, to continue.
All right. Well, and thank you for having us today. We're so excited to be a part of this important conversation. So just for those of you who may not be familiar with Parkview, and to provide a little bit of context around who we are a not-for-profit community-based health system serving a Northeast Indiana and Northwest Ohio population of over 1.3 million. We are headquartered here in Fort Wayne. We do have 2 hospitals here in Fort Wayne, along with a web of community hospitals in our surrounding counties. And then we also have a network of primary care and specialty positions. So just starting at the basics, starting with the foundational elements, the why behind what really got us started around this more concentrated path of social determinant of health work here about 3+ years ago at Parkview, are our mission and vision. And you'll notice that a few of these words are in italics. And with these key words in mind, we realized that our social determinant of health related efforts at that point just were not really truly fulfilling our aims. So we decided to pause, reset, and reframe. And as Sarah just mentioned, and as was mentioned earlier, we know that overall health and well-being stretches far beyond clinical components alone. So we began this system-wide initiative to better understand the way that we were screening for social determinants of health across Parkview. And formally, while social determinant of health screening has been in place for nearly a decade, we did realize and acknowledge that it was fragmented and siloed, and there was a lack of standardization. So the team that I am a part of, Population Health here at Parkview, we began with a raw screening tool. When I joined the team previously was comprised of nurse care coordinators. I was the first social support specialist to join the team, and we have since then balanced to more of an even team between RNs and social support specialists. We began seeing more of the importance of screening for these social drivers of health. So we moved beyond that raw tool that we started with toward EPIC's model tool to screen for social determinants of health. But again, across the system, we did not have a consistent set of screening questions that was being used, nor did we have any standardization around how those questions were being asked. So we had the spectrum that we identified where some teams were maybe more in the bucket of population health, maybe were more experienced with screening for, in a more formal manner, those social determinants of health. The opposite end of the spectrum, we had teams where perhaps they've not heard of what is a social determinant of health. Why is it important that we screen our patients for those needs? And then in the middle, we had teams where perhaps they were in conversation with their patients during visits, asking questions, but much more informally and not anything that was making its way into the documentation part of the EMR. So we had data that just was not meaningful and couldn't be used to springboard this work forward. And on top of that, we had conflicting opinions from leaders and stakeholders across the system around what the best way was to screen patients for social determinants of health. So we had this goal of standardizing our approach to collect, interpret, and use social determinant of health data across Parkview. And we began into this partnership, very meaningful and imperative to this overall work. But first, we started with this question of the screening tool itself. Do we stick with the model tool that was in EPIC, our EHR, or do we move towards a more customized list of screening questions? We identified some barriers, again, going back to just achieving that consensus among key stakeholders and subject matter experts that were internal to Parkview. And then also realizing and acknowledging that if we went the customized route, it would be a heavier lift for our IS team because that customization would require additional EHR build work. So this partnership with our research team internal here to Parkview, and then also our collaborators in research with the University of Michigan. So one of the first things that we did was a Delphi study that spanned the course of many months, but it was comprised of a diverse group of key stakeholders. And we looked at things such as what questions should be on our customized screening. What was the frequency of that screening? How often should we ask? What should that mode of screening be? And we did achieve consensus, and we were able to land on a customized set of validated social determinant of health questions. So we also comprised this social determinant of health advisory group, which includes a group of key stakeholders from a number of service lines across the health system. And this group is really helping to drive the work forward as we continue to operationalize our SDOH screening across the system and aiming to make sure that the collection of these important data are easier and more useful. So I really cannot emphasize this piece enough, how integral of a piece of the overall puzzle that the EHR truly is and has been for us. So it's allowed us to have a shared definition of the data and to have this standardized approach to interpreting and then acting upon the data. It's been mentioned already, but we don't want to ask just for the sake of asking. We want to be able to act upon it and better serve our patients because we have that data. And we want data that's visible and accessible across the entire care team. So we've heard, we go back to how siloed it has been historically. we want a patient, if they're working with home health care or inpatient case management, if they're screened for social determinants of health and needs are identified, and then they're going to see their cardiologist or primary physician a month later, we want that provider and that care team to have an easy, efficient means of being able to see, okay, this patient was screened recently. These areas in red were those that were identified as being at high risk. These were the interventions that were put into place, the resources that the patient was provided or connected with, and then to have that action plan around follow-up. Does it require additional resources? Was the patient able to acquire or obtain support and assistance, or do additional referrals need to be made? This here is our table feature that we use, and we also have a snapshot report that our Epic Care analysts built for us to ease the access and make it more visible across the continuum of care. So this is a list here of the domains that are represented in our screening. Some of the questions used within our customized tool are the same as what were already in use with our Epic model tool, such as the hunger vital signs. We did add 2 domains that were not part of or represented in Epic's model tool: childcare access and health literacy. And then we also have here a snippet sampling of questions that we use in our screening tool. There's been thought around things such as the ordering of the questions, which might be revised, just keeping in mind with the new CMS measure around hospital screenings that Dr. Giaquinta will speak to more about in a few minutes. But just the ordering of it, and even things around for intimate partner violence, for instance, using the HITS tool, because that is the tool that is validated for use with patients or individuals of all genders. So just some things behind the scenes, and that was also, those were components that were part of our Delphi study earlier on. So we had our set of questions and the build work in Epic was underway. So it was time now to begin thinking more about implementation in the clinics and associated workflows. So we started with 4 ambulatory pilot sites, and we chose those sites very intentionally. I talked about that spectrum earlier, and we chose 4 teams that were already more advanced and experienced in screening patients more formally for social determinants of health. And we have since that first pilot launched last June, that we've added additional teams on that have implemented and will continue to grow as on the outpatient side system-wide. But then also with that CMS measure in mind, we are now pivoting to also encompass the inpatient side so that we are prepared for that new measure. We completed and created this implementation toolkit that is available to our advisory group members through our team site. They can then share out and disseminate the information down to their teams. It has an array of resources, again, that spectrum in mind, for individuals and teams that are earlier on and newer to social determinants of health, along through to those who are more experienced. And it's a living, breathing resource, so to speak. So it's ever evolving and growing, and anyone can add to it in the advisory group that would be a resource that would be of benefit. And it's important to note that while we were working towards standardization of the screening questions, the actual workflows could vary from team to team. For instance, who introduces the screener, how it's administered, who collects it, how the patient will be connected to the resources, and then who has that follow-up responsibility. And thinking about just sustainability and growth of a program or project, the evaluation and monitoring components are essential. So we're continuing to work with our research team here at Parkview, and one of the things that they are underway with currently are user experience observations. So they are spending time with representatives from each of those 4 pilot sites, just observing the screenings being completed, asking questions like what's going well for you in using this process, what's maybe not going well, so that we can process improve going forward. And then it's also important, the program evaluation and monitoring, those components are also essential to just ensure that well-intended policies and programming don't inadvertently worsen disparities. Sarah?
Sorry, I needed to get to that unmute microphone button. So this has all been really foundational as we think about our approach to health equity in our communities. And at Parkview, we really kind of have these 4 buckets that we're looking at as we try and achieve health equity locally. And obviously one of the big ones is addressing social drivers of health and health behaviors. So you can go to the next slide. What's really interesting, I apologize, I know this is a busy slide, but what's really interesting is we have had so many of these community outreach programs for years and years and years at Parkview. So we knew there was a need to address social determinants of health before people were really talking about it, before we started screening within the clinical setting. And what has been so beneficial about this process that Lisa has outlined is that it has really served to connect our clinicians with a lot of this work that we were already doing in the community setting. So because so many of these programs really kind of grew from the community health and community well-being bucket, a lot of our clinicians did not know about them and they were not readily referring to them. And so food insecurity in particular, now that we're starting to do the hunger vital signs on more and more of our clinical encounters, it has served to be such a valuable connector for our clinical team to really truly utilize and understand all of this great work that we were already doing in the community. So under that social drivers of health, these are a lot of the programs that we have. Many are focused on healthy food access, and I really want to dive into one example of how we're utilizing the screening questions to really take advantage of some of our community programs. So go to the next slide. And I have to shout out 2 of my team members that run this. They're on the call right now. So a huge thank you to Michelle and Kylie and all of the work that they've done to grow this program and to make it so successful. So this VeggieRx program, it started about 4 years ago through a small community health improvement grant that they received around $20,000, and we served around 30 families with that. And we have grown this program over the last several years to become this huge comprehensive fruit and vegetable prescription program that we last year were able to offer to 174 participants, and it has grown to enrolling over 400 participants so far this year with a goal of 450, including children, and we are even doing a prospective diabetes study for this. So some of this is outdated data, but basically anybody that enrolls in this program, they receive vouchers and now a Fresh Connect credit card, and it gives them $50 worth of money that they can use to get produce, whether it be at a local farmer's market or at a grocery store such as Walmart or Kroger locally. And what we have seen is dramatic improvements in blood pressure, improvements in general health. We've seen decreases in A1C and increased fruit and vegetable consumption in nearly all of our participants for this program. And when we first rolled this out, what we noticed was there were a lot more patients outside of Parkview that were contacting their provider and saying, hey, what a cool program. We saw this on the news, or we read a press release about it, and they were contacting their provider and saying, can you get me the referral to be a part of this program? And so now it's our goal that now that we are more routinely scheduling or screening for social determinants of health and doing those hunger vital signs, that we're going to have more of those referrals coming internally as well. So go ahead and go to the next slide. Our priority population for this, and these are 2 of our VeggieRx graduates that are showing some of their great outcomes that they've had, but we are targeting patients with a diet-related chronic disease, so diabetes, prediabetes, heart disease, hypertension, or at-risk pregnancy, and we've been able to expand that to even some children with obesity. And to be low income. So they have Medicaid, they're dual eligible, they're uninsured, or they've screened positive for food insecurity questions. And again, that's just one way that we have been able to really connect the dots for a lot of our internal providers to these community health programs. And it's happening at a good time because we have received over $1 million from USDA to continue to expand this program. And we are even going into 3 surrounding counties in the next couple of years to start this program. Go ahead and go to the next slide. So I think we saw these before, but these are those hunger vital signs. This is what we're trying to do as a part of our social determinant of health screening program that we're putting into place here. And next slide. What's been really nice is we have been able to have an EPIC referral. So in the same way that if you have a heart disease and you would refer to a cardiologist, we're establishing this 260 ambulatory referral to VeggieRx. And then if you go to the next slide, we now are going to have a food assistance and support team at Parkview. So getting that 260 ambulatory referral in place allows our providers to refer patients not only to VeggieRx, but they can be linked up with a community health worker that can kind of help them navigate this really complicated world of food insecurity and help them identify the place that's best for them. So whether it be starting with an emergency food pantry, enrolling in a VeggieRx to Heal or one of our healthy food box programs, and then hopefully getting them with their SNAP benefits and being able to use that to get to that place of food security. So again, we could not be here without the structure of the EMR, the structure of having the hunger vital signs being readily available. And we're so excited to have this kind of be this great continuum of care that we're able to offer our patients around food insecurity. Next slide. And this is a little bit of a boring slide, but I just put this in there just to show that it's not just hospitals that are finding importance and value in this work now. We have CMS, we have the Joint Commission. They are all shining a big spotlight on health equity and those critical steps it takes to achieve health equity in our communities. And you can see number 2 is assess patients' health-related social needs. So now is a really opportune time, I think, to help facilitate all of these connections between what's going on in the hospital and clinical setting and all of these wonderful community resources that likely you guys are a part of, because all of our health systems are now going to be accountable to this work. And so if you don't have that connection yet, you will, because we have to have this. We have to do this to really serve those needs and truly have a comprehensive approach to health equity. Next slide. Okay, I'm going to turn it over to Lisa for the remaining slides.
Thank you. So when I think about having a community resource directory, I kind of laugh to myself when I think back to how it started out when I joined Parkview. Was there were binders of printed off resources that any navigator or coordinator, anyone doing the similar work in the system at that point had, that they had for each county that we have patients living in. And you can imagine how obsolete that those binders would come very quickly. And then it's not the best way to serve our patients because perhaps the hours at the food bank changed and we didn't realize it based on what we had in our binder. So we several years ago partnered with Find Help, which was referenced earlier, formerly known as Aunt Bertha. And it's a national social care network. And it's so integral for us as a health system to be able to effectively connect patients with resources to meet their needs. So we have, again, I mentioned this earlier, we don't have a single role or job code that's doing all of these screenings. So it could be a medical assistant who's rooming the patient. It could be a nurse or some sort of a navigator role. There's an array of roles that could be doing these screenings. And so we need a very user-friendly and effective means of being able to identify what resources are out there to connect our patients to based on their identified needs. So Find Help allows us to do that. We also have a goal of making it as accessible to our patients as possible, so that, if they're not currently maybe actively working with a navigator, or maybe it's 2 o'clock in the morning and they just got off work and they have a need, they can also self-navigate. So we have panel cards that have a QR code for our Find Help website. Parkview.com, our main site, has the link on there. Our My Chart, patients can log into and access Find Help from there. There is a translate function, which is so important for being inclusive for those patients whose first language is not English. And then, of course, if we have patients that don't have access to the technology, we can, if we're working with them in person, print off the information for them. We can mail it to them, whatever works for the patient. So it really is integral to us being able to act quickly and efficiently around those identified areas of need. So we also are working towards just thinking about because there are a few different versions of Find Help. So thinking about which version aligns best with our need. There are some conversations that we are still navigating with our legal team around just the disclosure of information. And we also want that visibility component to come into play. That's huge, as it works to tell that patient's all inclusive story, so that we can see very easily, these were the resources that were provided. This was the assistance that the patient was able to get connected with. And then looking ahead, we're always looking ahead, thinking about growth and sustainability. So I talked earlier about that program evaluation and monitoring, and those components will be ongoing, and we'll continue to partner with our research team and work through just growing that. Thinking about referral and navigation opportunities. So we, yes, want to develop and solidify those partnerships in the community with our community-based organizations that are working to help serve our patients with us, but also just having a streamlined method of identifying internal resources. Parkview is ever growing, and new roles and resources are popping up continuously. And sometimes, if it's not something that one team works with or collaborates with on a daily basis, it's hard to know what all is available. So one of the resources that we have in our implementation toolkit is an internal resource directory that anyone can add to, but it's just a compilation of different internal resources that not only could we consider external to Parkview, but also internal, different teams that might be able to help serve our patients with those needs. And just thinking of how can we enhance our staff training and education around these screenings, demos of Find Help, making sure that everyone is comfortable in knowing those resources and how to leverage that functionality. So we're thinking about, too, with Find Help, thinking about closed loop referrals. And again, those are ongoing conversations with our legal team as we work out some of those details. But just thinking the importance, we've talked about that whole full circle story across the continuum of care. If we could see in their chart, in their EMR, that yes, they were referred to this food bank and the referral was accepted, and the patient came in and was able to get assistance. If we could see that without trying to then contact the patient back, and sometimes we don't reach them, or we're left wondering, did they get assistance? So leveraging that functionality and the technology to help us know that piece of the story. And working to engage more of our community-based organizations into just our network of supporting our patients. And I talked about this, but documenting those interventions so that story is told and it's clear of, what organizations has a patient already been referred to. I know I've had patients before where they feel frustrated because they've been sent to the same, or they've been given the same information multiple times, and maybe they went to that organization once and for whatever reason didn't meet criteria. And so we'll know that and be able to offer a different possibility or solution. So, and then just thinking about, again, leveraging the data to help us grow this, know where the needs are, and be able to put resources towards those identified needs going forward as a health system. The importance of the data, capturing and analyzing that. It's important that we have consistent definitions and reporting. So working to build a data dictionary with our Epic Care analysts, dashboards going along with that. And it also helps to serve to reinforce the why behind why we're doing what we're doing, reinforcing that buy-in, creating a standard metric system for how we're asking, and even thinking about patient satisfaction. That can also be a factor in how we going forward through program evaluation and monitoring. Do we need to adjust our process? So that is something that we will also be looking forward to going forward. And then just our last slide here, just our kind of lessons learned or themes for pillars for success for us have been collaboration, both internally and externally. Again, I mentioned University of Michigan and our Miro research team, and then our community-based organizations and all of the teams within Parkview. Just understanding the current community needs. So looking to our community health needs assessment, standardizing where and when possible, leveraging that EHR functionality, and education ongoing so that we can keep up with where the needs are located. All right, and that was my last slide, Julia, so I'll turn it back over to you.
Wonderful. Thank you so much for sharing. At this point, we're going to open it up for questions. So if you have a specific question for a specific team, you can go ahead and say that. If it's a general question, we can just ask and anyone can jump in and answer based on their experiences. So feel free to either unmute and ask questions, or you can put it in the chat and we'll ask.
So I had an interesting question. Hi, I'm Yvonne Hensley from Mother Hubbard's Cupboard here in Bloomington, Indiana. So some things that I hear a lot of is that a lot of BIPOC people and people who are of Native descent, we don't tend to get allergy testing, and many insurances don't tend to, unless they get a doctor request or something like that, they don't pay for it either. And so we tend to just decide just to eat whatever is quote unquote healthy. So with that being said, I know there's always one, we've been looking for a program that would help facilitate, I don't want to say purchasing of an allergy test for a lot of BIPOC people, a lot of lower income people, so they know exactly what they're allergic to, so that they know exactly what's healthy for them, what's nutritious for them in the long run. Because we find a lot of people who are BIPOC are also very lactose intolerant. They can't have soy. So I wasn't sure if that's something that is also in your guys' programs up there, or if that's something you've talked about, and either program.
I don't know if Parkview has, I don't know specifically, other than, we have a very large group of dietitians who are very helpful for a lot on an individual basis. So sometimes in group visit type programming, it's not as helpful, but in their individual patient assessments, certainly they're trying to work individually to uncover maybe some of those areas. Additionally, I don't know for your program, but a lot of our more emergency food pantries have been very overrun, where some of even the choice food shopping has been more limited since the pandemic and the increased need. So we currently are conducting surveys to medically tailor and culturally tailor food options, both within Crooked Creek Food Pantry, and then we hope to be able to utilize that at the Eskenazi Fresh For You Market. And essentially the surveys are to listen to people's food allergy needs, religious needs surrounding food, cultural preferences, what types of, fresh produce items do they want? And then we're using funding to see whether or not in, our Crooked Creek Food Pantry, for example, is still a drive-through options because of the demand. It's serving over 4,000 households a month right now, and that volume is already stretching them. So how can they have options for people who have food allergies or religious food preferences, or are new immigrants and have cultural preferences in the foods they want? So collecting that data and trying to figure out how to best serve. That's more of a pantry type of option, but maybe Parkview has something else that comes to mind, or Dr. Callahan, since that was just the first one that came to my mind.
I would just jump in. I echo a lot of your responses. Access to allergy testing has not really been a part of these programs. I think the foundation of really what we've been doing from a community health and well-being perspective is that intense focus on fresh produce. And so it's really about meeting those health needs and the cultural needs. So like Dr. Reynosa said, cultural fit has been much more of a focus for us. So we have a high Burmese population here. So at our heel farmers markets, we have a Burmese farmer who comes and has vegetables that a lot of that population would not be able to find in a traditional grocery store or market around the city. So that's really been a big part of our focus. I think it's an interesting point, and I would be curious to take this back to our community dietitians to see if this is a question that comes up frequently with them. So thank you so much for that.
Well, thank you guys, because I do an advocacy program here called Coffee and Chat, where I just talk with patrons, and a lot of our funding got dramatically cut because of the pandemic. We serve almost 2,000 people here in our just our small pantry that we have, and I get questions from allergy testing to vitamin deficiency testing to things of that nature, because they just ask us what are different things that they should eat for energy level or stress and gout, and I mean, you name it, they ask us all kinds of things, and there's things I have no clue. I'm trying to get a nutritionist just to table at least once a month here soon. So thank you. Thanks.
I see. I was going to say there's a question that I'd love to start answering that was put in the chat. You're both large hospital organizations. Any suggestions for how a small rural hospital might implement this? So that is a great question. And I would say that with a lot of this work, we really did start small, because it's very hard to start with an entire health system. So I think when you're thinking about the programming piece of this, you know your community and your resources better than anyone else. So whether it be a farmer's market or a local food pantry, that's who I would start talking to about what resources are available in your community and the best ways to connect patients to them. When we started VeggieRx, it was a very small grant, and even that grant wasn't completely utilized. And we were able to grow the program and then get external grants to support that. So you don't have to have hundreds of thousands of dollars to start some of these programs. You can really start small from a funding perspective. And then from a screening perspective, start one clinic at a time. it's all about piloting and then figuring out what worked and what didn't work. And I don't know this for sure, but my guess is Eskenazi is continuing to figure out how to improve these processes. We are certainly always in that place. I think all of healthcare is. And so I would just encourage you to start somewhere, start small, and then you can always change and grow as you figure out what works best for you.
And then perhaps also, oh, go ahead, Dr. Callahan.
No, you go ahead, Lisa. I'll go after you.
I was just going to add to what Dr. Giaquinta said, just maybe partnering with your medical record vendor. I know our Epic Karen lists have been hugely just advantageous. That partnership has been invaluable. They helped us get started, and even before, I don't know the structure of your health system, but before we even had a glimmer of the CMS measure on our radar, we were even thinking with our small pilot sites, perhaps starting with the lower hanging fruit, so to speak. So those domains that your community has more resources readily available for. So food insecurity was one that has always been on our radar because, here locally we have more resources available to meet those needs. Housing is more of a challenge because, those resources are more strained. So maybe even thinking about strategically what makes sense for your system and your community from that lens.
I was going to say two things. One is in this walkabout to see what your community assets are and what sort of resources you have. I think you're very likely to find some willing volunteers to help you launch it. I think a lot of our programs are driven by volunteer help, and oftentimes there are people that have been in this situation themselves and would like to give back. The other thing we always say, and I think I know Dr. Reynoso would agree with this, but Dr. Giaquinta and Ms. Knox have also alluded to it. There is a strength in a small rural hospital that does not quite have the ginormous bureaucracy and 17 parallel programs that we're trying to bring under one umbrella. So you could say we're small, but we're probably more agile than the larger organizations.
All right, Dr. Inoso, anything else to add to that question?
No, I was thinking the same. I mean, we didn't roll out everywhere to everybody in the same week. And similarly, we didn't mention it, but we also started with our 14 federally qualified health centers and our mental health before, getting to the point where we're looking at some of our specialty and inpatient. And so, with a larger system, it is a big task to have everyone doing things in a way that can be seen across the system, because, you don't want someone in the emergency room doing screening and giving a resource, and the next week, someone doing the same screening and not following up on whether or not that resource was helpful. And so there is difficulties with being smaller, of not having the same, breadth of maybe resources, but a lot of this is also with larger organizations trying to get it so that it is moved forward in a thoughtful manner, so that ultimately our neighborhoods have improved access to what they need for living long and healthy lives. So I guess that was just me thinking the same as everyone else from the group.
Wonderful, thank you. And I think, Debbie, your question was answered in the chat, but for those who might not have access to the chat or viewing the recording, there was just a question of why there was a partnership with the University of Michigan rather than an Indiana-based institution. And Parkview has a longstanding relationship with the University of Michigan for grants and research projects. So that's why that decision was made. All right, does anyone else have any questions for our team? Or do you all have questions for each other as you've listened to your presentations and how the systems are set up?
I have a question. Does it matter if a hospital is, do they have the same incentive to do this if they're a for-profit hospital versus a not-for-profit hospital?
I will say that for either a nonprofit or a for-profit hospital, the kind of end game to make this sustainable that Lisa mentioned is many of us are trying to demonstrate to third-party payers that if they would invest in these types of programs, they would see better health outcomes for the patient and their families, but also for the cost of healthcare for the nation in general. That's a very difficult question, but you see it on a small scale. Like many of us have either pilot projects or observational studies, or some sites have randomized trials where if you control nutrition, you don't, you'll see an improvement in diabetes, or someone won't be able to come off of their high blood pressure medicines. One of the frustrations of healthcare providers in general, if you look at an issue like hypertension, for almost 100 years, we've had medications that in a controlled setting can control hypertension. And we've known that lifestyle interventions, if they're applied over the long term, have the same effect. But every time a health system surveys itself or the nation, only about a third of the people with hypertension have it controlled. And we could say the same thing about diabetes or weight gain prevention and any of these chronic conditions. And so people have said, well, is that going to be fixed by fancier medicines, or more medical care? Or ought we not be looking at some of these social factors that might be explaining it? And I think we have, all of us as a group, have the attention or maybe the interest of those third party payers, but we have not delivered the compelling proof yet.
Thank you.
I think the only thing I would add is, and I guess we're both not-for-profits here, I think there is probably more resources available in a not-for-profit hospital for this kind of work, from the perspective of we are tracking and continuing to track our investment into the community to keep our not-for-profit status. That's a really big part for all not-for-profit hospitals. And so for me, if I can go to my leader and say, hey, I've got this great program that will be both a community benefit and will improve health, I think you're probably going to have leaders that are more willing to invest in that to some level, because it is truly our mission is to do that. I think I think for-profit hospitals also have probably good intentions. I just don't know if there's as much resources that they can commit to the community benefit piece of that. That would be what I would be wondering.
Thanks. That's helpful.
All right. Any other last questions?
It was really nice hearing from Parkview coming into this, and I think further collaborating for things, because looking at your dashboard and seeing the screening questions, and as we're building how to close loops and follow up, especially using the same the EMR and the Find Help. I'd love to follow up with both of you, but if there's other organizations here too that have interest, I think the collective impact for our state of working together and not reduplicating some of those efforts. So I'd love to have a follow-up meeting as well as you guys continue to move forward, and us as well. So thank you.
Thank you to you guys. We would love that. And thank you to this group. This was a really nice meeting, really fun.
Yes. Thank you so much, everyone.
Wonderful. Yes, thank you. And if anyone knows an organization that would be interested in what Dr. Reynoso was just talking about, please reach out to me or to anyone who presented, where you will provide that contact information, and we'll send out the recording and the slides next week. So thank you all so much for your time, and have a great rest of your day.
Thank you.